My name's Kyle Sears. I'm your Zoll rep. We're going to go through the X Series Advanced today. So it's the X Series that you guys are used to using, plus some additional features. Okay. So all of the, both fire apparatus and all the ambulances will all have the exact same monitor, same configuration, everything like that. Sound good? All right. So first thing that you guys will notice different in the right-hand pocket, the ones that are set up with bags, is this defib cable. Okay. So this is a universal cable that's going to accommodate any Zoll pad that you're going to come across. All right. And the reason we're doing this is because a lot of the hospitals around here are going to stock different types of pads, right, depending on what they're using usually inside the hospital. You'll have this cable will be your, well, I'd consider like your standard cable. You'll always have it set up like this. You will leave the pads unplugged until you go to use them on the patient. Okay? Depending on what pad you're working with will dictate whether or not you put this adapter on. Okay? One of the more popular pads now that you're going to come across are these. They're called one-step CPR pads. These are very popular in the hospital world because it allows you to come in with a patient. They can disconnect from your cable and plug right into their cable on their in-hospital Zoll monitors. When these come out of the package, they're applied to the patient exactly how it looks right here. So the red pad goes on the back, the triangle stays connected to the puck, and that goes on the front of the patient like that. The end connects to the defib cable just like this. Those clip together. Okay. If you have to treat a pediatric patient, you cannot use the auto pulse on pediatrics, right? So you'd have to do manual CPR. You'll use this pad, which is called a one-step pediatric CPR. Comes out of the package. It's applied to the patient just like this. When I connect this to the defib cable, you'll hear the monitor beep, and it lowers the energy level. So instead of starting at 120 joules, it'll start at 50 joules for a pediatric, and it'll go 50, 70, 85. Okay? Unless you guys dial in your, if you're a medic, you can dial in your 2 to 4 joules per kilogram based on their weight using the energy select button, and it'll shock at whatever you dial it in at. Okay? The last style that you may encounter are what you guys are used to using now, these CPR stat pads. These provide the CPR feedback. The connection looks like this. This is also consistent with any Zoll AED that you'd come across. So like if you guys went to a health club for a call and they had a Zoll AED, the AED itself would be this color. It would say Zoll on it, obviously. You could take their pads right out of their machine and you can plug into this cable, but then you go, oh, wait a minute, like there's no way to connect these two. And that's when the adapter comes into play. So you connect this, and now you have the ability to accommodate that style pad. Make sense? All right. So you guys are used to getting CPR feedback, right? Everybody's comfortable with that. You're used to applying the auto pulse. The feedback goes away. It just says auto pulse on the bottom. So I'm going to have somebody come up who wants to come up and do CPR real quick. Anybody?
I think Gary needs more practice.
Gary? Is that your name, Gary?
Yep.
All right, so Gary's going to do CPR. All right. My job as Gary's partner is to get the monitor turned on. Right? None of this is different. I want the monitor facing him. Go ahead and start whenever you're ready. Okay. Right. Picks up the rhythm. He starts doing compressions. Okay. All of this is familiar to you guys, right? So just a quick review. Normal rhythm with artifact. On an actual patient, you'll see this rhythm eliminating the majority of the artifact. So you can look at the underlying rhythm of the patient while you're doing compressions. Then you have your depth. You want the numbers to be green here. So between 2 and 2.4, it'll be green. If he's going too deep or too shallow, it'll be yellow.
Push harder.
Say push harder. Yep, you're good. The beeping that you hear is set at 105 compressions per minute. You'll only hear that when you're doing manual CPR. So every time he hears a beep, he should do a compression. Okay. It's going too slow, right? So we just want to pick up the pace a little bit. Just get on beat with the metronome. This white bar right here is your release indicator. So that's showing whether or not during the decompression phase, he's allowing the chest to fully recoil back to its starting point. Okay, and that's what helps build up good perfusion. This little indicator right here, this triangle, you want that diamond to be full as much as possible the entire time you're doing compressions. And then we have our CPR timer tracked right here. So he has 38 seconds left on this first cycle. This information all goes away once the auto pulse is applied. Okay?
Push harder.
So it'll just say auto pulse across the bottom. You won't hear the beeping.
Gary's getting tired.
Right?
Well, it's clicking, I don't.
Good compression.
Turns out Gary's terrible at CPR.
In fairness, you can't see the screen, right? So you're going a little bit slow, but you have 5 seconds left. Okay. You can stop now.
Gosh. I'm gonna be like,
Thank you.
I forgot we're on video.
I know. We got proof now. Everybody's comfortable with that, though? Right? You guys are used to seeing that. That's no different. Nothing has changed here. The one thing we're not managing currently, though, is our airway, right? The quality of our ventilations. So the next major feature change is the ability to have real-time, not CPR feedback like you guys have had for a while, but real-time ventilation feedback. So every time you ventilate the patient, all right, so if I'm sitting there bagging this patient, and I know that I should be bagging them because they're an average size adult patient, right? My target would be 450 mLs every time I squeeze this bag. And I want to ventilate them at a rate anywhere from 8 to 12 ventilations per minute, with ideally we'd be targeting 10 ventilations per minute. Okay. Do you guys think I'm doing that correctly? I have no idea, right? And that's sort of the whole point. You guys have no idea if you're doing that correctly right now. The assumption is you're not doing it because it's really difficult to maintain that over a period of time. So in the far right-hand pocket, you're going to have this cable, and you guys can open your bag just to look at it. Okay, you guys see the cable? I'm sorry, not the blood pressure pocket. Go in the pocket where your defib cable's at. I said far right, and you went in the far right. So everybody see your cable? And everybody look at the difference of my cable versus yours. This piece right here is disposable, okay? So this is one-time use. It gets tossed out after every patient, and it clips into the part that you guys have that is in your hand right now. So this is measuring the amount of air that I'm providing to the patient. No matter what situation it is, if I'm manually ventilating a patient, it's going to measure that airflow, okay? So in this case, on a cardiac arrest patient, whether it's hooked up to the BVM or using any sort of advanced airway, I'm going to be able to measure every time I ventilate this patient for both volume and rate. Right? So the bottom right corner of the screen, you'll see a couple numbers pop up there. The first number on the left is the volume of air that you're providing every time you squeeze the bag. And for an average size adult patient, your target is 450. And if I'm between 400 and 500, so you get plus or minus 50 either way, it's going to be a green number, right? So I'm guessing just based off feel, I was probably too high, right? Is that accurate? Okay. The circle in the middle is going to count me down. So it starts at 5, and then every time it gets to 0, that's when I ventilate. And that's going to help me track my 8 to 12 ventilations per minute on the far right-hand side. So target being 10, plus or minus 20%, we're going to get a green number on there. Right? So I still have no idea what I'm doing because I'm not looking at the screen. But a lot of you guys, as you get the opportunity to mess with this, you're going to go, oh, well, muscle memory, I'm used to doing it like this. Right? I'm providing way too much air, especially older medics. They were taught to be I'm going to squeeze as much air as I possibly can into this patient because oxygen is good for people, right? That is not true because too much oxygen is going to build up this real strong positive pressure in their chest cavity, which prevents good preload from happening during a cardiac arrest call. And it also prohibits good oxygenated blood from getting back to the brain because there's all this pressure built up in the chest cavity. So you don't want to hyperventilate or overventilate this patient.
Now you're green.
Now I'm green, but I'm going too fast, right? So the last class that was here this morning, the last call I was on, he's like, the guy was probably ventilating 70 ventilations per minute. He's like, what are you doing? Like, it's just, you go way too fast, okay? So nice and slow. So now if you look at the screen, it's a lot easier, right? It's like playing a video game at that point. I'm going to wait for it to count down. Right. So when you have all this going at the same time, you'll have your normal rhythm, your underlying rhythm. I'll show you capnography here in a second, CPR feedback, and ventilation. So now we're not missing anything, right? That was the big thing. We were missing the airway piece of this. And again, we're looking at it during a cardiac arrest. This is true anytime you're manually ventilating a patient. So the other example we use is like an overdose patient. If an overdose patient aspirates while you're treating them, they have a 70% higher chance of dying. Right? They get aspiration pneumonia, they're probably going to die eventually from that. So it's really important in those situations too to make sure that you're not hyperventilating those patients and they end up throwing up. Now this is measuring the amount of air going into the patient. So you want it as close to the source of that air that you're providing as possible. That's why it's clipped up to the top. So now the next thing we're going to measure is the pressure of the CO2 leaving the chest cavity, and that's going to be done with the end-tidal CO2 adapter. Okay, so that's going to be as close to the patient as possible. Now you have two pieces, right? But you have this space in between. The space in between is going to be your rescue pod and your filter. Okay, and it doesn't matter what order they go in. Okay? So let's talk about end-tidal for a second. The end-tidal disposable, right, you guys are used to seeing this, but the feedback I got the last couple days is, oh, there's times where I don't have end-tidal, and I'm expecting to, right? I don't see it on the screen, or it never comes up, or whatever the case may be. So the best practice for end-tidal is the third button down here. You're going to hit that button first. Okay? And what just happened was the monitor did a quick little like purge of air, right? And now it's ready to go. You can hear that rumbling sound. So now is when I want to plug the disposable in. If you plug the disposable in first and then hit the button, it's got to purge air through this whole tube set, which can take up to 2 minutes for that to happen. So if you're sitting there waiting for a waveform on the screen and it's still doing the purge, you're not going to see a waveform. And then you're going to go, did I do this right? Right? Is something broken? Do I not have this tube placed properly? So always hit the button first, plug in your end-tidal, and now it's ready to go. My battery's dying. So now I'll have end-tidal, the different waveforms, and then all my feedback on the bottom.
Push harder.
Okay. I'll pass out. Does that make sense? Good? So next thing to look at, this little RX symbol. It sounds like some people are maybe using this, some people not so much. But the RX, we call those code markers. So if you want to mark the fact that something happened on this call, like you can hit event, epi, intubate, lidocaine, Narcan. We can make these whatever you guys want. But every time I hit that button, it lights up blue. So it puts in the memory of the machine, hey, at this time, you administered lidocaine or Narcan or whatever button that you hit. And then at the end, I'll show you how to upload all of this into your patient care report electronically. Okay, so we're going to move towards doing that too. All right. Make sense though? Okay, let me switch my battery out real quick. So from a user perspective, that's a big change for you guys, right? It's another tool for you to use. We're trying to make these like more valuable, right? These are very expensive devices. We want to treat more than just cardiac patients. Here's what it looks like on the screen. This is what we just looked at, just to give you an example in sort of a static environment. So the next thing we're going to look at is traumatic brain injury patients. So this is our first sort of entry into this world of what we're calling dashboards. And dashboards are going to allow you to treat different types of patients and make sure that you're monitoring the things that are important during those types of treatment. So you guys are used to this page. You're used to this page. You now have a third page of options. And the first dashboard that's been released is this little brain, and it's got a bandage on it. So if we're treating any sort of head injury patient, we can go in here, we can hit this button, and this screen's going to pull up. Okay, and this is your traumatic brain injury dashboard. So the reason this is important, let me try to use analogies here. If my responsibility this afternoon would be to bake you guys cookies, okay, there'd be a very specific recipe that I would follow to make those cookies and make sure they tasted good. If I mess up any one of these ingredients, these cookies are going to be bad, right? So if instead of putting in like 2/3 cups of sugar, I put in 2/3 cups of salt, you're going to be like, these cookies are terrible, okay? And the same is true for traumatic brain injury. If I follow the ingredients correctly, that TBI patient is 2 to 3 times more likely to survive that injury. But if I mess up any one of the ingredients or the way that I treat these patients, they're 2 to 3 times more likely to die from the injury. Okay? For you guys, your recipe book for a TBI is 90, 90, 10. Okay, those are the only 3 numbers that you got to remember. And these are tracked here as well. So the 90 is your systolic blood pressure. You want to make sure these patients don't become hypotensive, because if they do, they have a 2 times greater chance of dying. So your 90% systolic blood pressure, when I go into the TBI dashboard, my automatic blood pressure gets turned on without me doing anything. So every 5 minutes, there's going to be a blood pressure that gets plotted out here on this little graph. And you want to make sure that number is always above 90. So from a trending perspective, and I know you have a short transport, right? But as you're treating this patient, every 5 minutes, you're going to get a blood pressure. You want to make sure it doesn't fall below 90 at any time. The other number is 90% SpO2 or higher. So you want to make sure this patient doesn't become hypoxic. So you'll start to see a trend line here of your SpO2 and whether or not it stays above 90 at all times. The ventilation feedback we looked at earlier is going to track your last one, your 10 ventilations per minute. Because the last thing you want to do is hyperventilate a TBI patient, because all you're doing is continuing to injure their brain by adding pressure to it. And then your end tidal is going to be between 35 and 45. So you'll see a waveform right here. If you want, now this is tracking the waveform of the numbers, right? If you want to see the actual capnography waveform, you can hit CO2 and have that waveform on the screen as well. Okay? So all of these things get tracked. Again, if I mess up any one of these, right, ingredients are going to give me a bad cookie. Here's what it looks like on the screen as it starts to get plotted out. So there's that little plus sign right there in the bottom left. That's where my blood pressure gets measured. My SpO2 trend line, see how it starts to droop off there at the end? And then those little arrows are saying, hey, what's going on here? Like they're below 90 right now, right? We want arrows pointing up. And the same with our capnography between 35 and 45. Right. Any questions on any of that? It's stuff you're doing already. It's just a matter of putting it in one window and giving you a reference on where it needs to be versus where it currently is on the patient. Okay? We'll eventually have sepsis dashboards and stroke dashboards. That's sort of the route we're going down the road. Cool? All right. I'm going to exit out of there. A couple little things just kind of through the years here and feedback from people. When you acquire a 12 lead, you guys know this and you're probably doing this already, but just as a review, the common theme is that you're taking a picture of the patient's heart. So there's the camera with the number 12 right here. So when I hit that button, it's going to prompt me to put in the age and gender of the patient. Once I do that, usually we'll see a lot of people, they'll go all the way down to this bottom arrow to actually acquire the 12 lead. Right? So let's say it's 1, 2, 3, 4, 5 button presses to get down to the arrow, and then 6 button presses to enter it. How about instead of doing that, you just put in the age and gender, and then you hit the camera with the 12, and then it starts to acquire. All right? So It's just 5 less buttons that you got to press. Okay? You have a stop sign. If for the first 5 seconds of the acquisition you look and you're like, oh, this is going to look like garbage, just hit stop. Get the patient to settle down, readjust the electrodes, whatever you need to do, and then you'll have the ability to go in and acquire it again. Right? The other change is now all of the monitors will have the ability to monitor both SpO2 and carbon monoxide. So this finger probe, a couple things are different on here. You're going to put this on the patient's non-dominant ring finger. So I'm left-handed. My right ring finger over the course of my life should have the least damage, the best capillaries, and the most perfusion, which should give me the best reading of all of my fingers. Right? If you have a patient that has smaller fingers, you can take their finger, and if it goes, this is like a sizing guide basically. So if it can go past their nail bed on the other side, so finger goes through past their nail bed, then you should use a pediatric probe in that case. Right? Even if it's an adult patient, just means their finger's too small. So what you're going to see now is the bottom right-hand corner, they're going to have, get out of exit. The bottom right-hand corner is going to be a big number. That's SpO2, which you guys are all used to looking at for your entire careers, right? But SpO2 is giving you total blood gas saturation. It's not taking into account what percentage of that big number is specifically made up of carbon monoxide. So for you guys coming out of structure fires, that's important. Ideally, you'd have a baseline for everybody established, and you can reference that baseline to say, hey, normally they're living life at a 4, and now their CO level's at 12. Well, you know that patient had overexposure to CO. Okay, it can be anywhere from 0 to 10, or 0 to 9, and then at 10%, there's going to be an alarm that goes off. Right, it'll be a red light that flashes. So big number SpO2. Total blood gas saturation. The little number, CO, is specifically carbon monoxide molecules. You want it to be 9 or lower. The other number you're going to see underneath here is something called a PI, or perfusion index, and that's new to you guys as well. So the perfusion index is going to tell you whether or not the finger probe is able to read effectively based on the amount of blood that's getting to the tip of this finger. So the PI you want to be 1 or higher. If it's not 1 or higher, you can't have confidence that those other numbers are correct. Does that make sense? So the PI can be anywhere from 0 to 20. You have to have it higher than 1 to know that those other numbers are reading correctly. I've never seen it higher than 11. Right? That's the highest I've ever seen anybody. And that was somebody who had just got done working out and they came into class. So they were fully perfused, their blood was flowing. But this would be like an example if you went outside in the middle of the winter and somebody's finger was really cold and you put it on and their PI is like 0.4. Well, you don't know whether or not those other numbers are accurate, right? So you warm up their finger, you switch to a different finger. Maybe they have dark nail polish on. You can try to twist their finger sideways, right, and try to get a reading that way. Okay? Is nobody talking because we're being recorded? Because this is super uncomfortable. All right, I just want to make sure. Please ask questions. So uploading to the PCR, and I'll get you the steps on this. Don't worry about knowing these by heart. Second page of options, the log button right here. These allow you to print, right? We know that. This little white envelope right here is going to be where you upload it to your Zoll report, okay? So step 1, you go to the white envelope. It's going to say, well, what do you want to do? Do you want to close the case, which means the current call you're running on? Right? You're locking up the file, you're pulling into the ambulance bay, this patient's not going to die, right? Or are you doing this 20 minutes later and you want to go into all the calls that have previously been run? And in that case, you'd go to continue. Ultimately, it's going to bring you into this window either way. You just want to make sure you're pulling the right call, and that's going to be dictated by the time and the date and the duration of the call that are listed here. Okay? It's probably going to be the first or second one, depending on when you're doing this, but you want to hit enter to select your case. You're going to select the case by hitting enter again. You'll see a little green check mark come up next to it. And then right here it says press home key to exit. And what that's telling you to do is you exit this selection criteria. So I'm going to hit the home key, which is the one with the house on it, and then transfer gets highlighted, and I'll hit enter. Then you'll see a little screen here, and it'll say % complete. The time that it takes to complete this will be dictated by how much data is on the call, right? So a 30-minute cardiac arrest is going to take longer to upload than a 10-minute BLS call. But what happens is it goes to Zoll, and then we're going to program your Zoll PCR account to look into this Zoll account, and it'll go, oh, there's a new call from Medic 4. Let me grab it and make it available. So if I'm on Medic 4 and I'm sitting down to do my patient care report in my Zoll program, there are tabs that you can select and say, yep, that's the call that I want to associate with this patient that I'm reporting on. And then you're going to get all of your strips, all of your vitals every 5 minutes, and anytime you shock, cardiovert, pace, or do a 12 lead. Okay, so all that will pre-populate those fields. Those fields of which you can go in and edit. Okay, so if anybody in the room right now is like, oof, I don't know if I like that, you can go in and make the edits on your PCR report. Right? Times, dates, deletes, everything like that. Okay? We want you doing that. It helps you write your report faster. It also gives you the ability internally to QA those calls as well. Right? So a cardiac arrest call, ideally you'd upload that call, and in a perfect world, whoever's analyzing that could sit down with the crew that ran that call and be like, all right, let's take a look at what happened on this call. What did we do well? What do we need to improve on? And from a department-wide perspective, next time training comes around, they could be like, hey, Medic 4 is notoriously shallow on their compressions on black shift, right? And get that specific so that you guys know what to